Today we will discuss prokinetic drugs. So what do we mean by prokinetic drugs? Pro means promote or increase, and kinesis means movement, so increase motility. So prokinetic drugs are drugs that promote motor function of GIT or increase GI motility. Now intestine is supplied by enteric nervous system along with sympathetic and parasympathetic nervous system. This enteric nervous system can independently control intestinal secretions and motility. This enteric nervous system can independently control intestinal secretions and motility. It consists of two components. First, Meissner's plexus or submucosal plexus, which is located in submucosa. It is responsible for control of secretions. Second, myenteric plexus, which is located between outer circular and inner longitudinal muscles of GIT. This myenteric plexus controls GI motility. Now the main component of enteric nervous system is the primary cholinergic neuron. Let's suppose this is the primary cholinergic neuron. Now this neuron secretes acetylcholine, which acts on M3 receptors in intestinal smooth muscles. Now there are also interneurons which affect the primary cholinergic neuron. These interneurons can be excitatory or they can be inhibitory. So this is the excitatory interneuron and this is the inhibitory interneuron. The excitatory interneuron secretes acetylcholine. So acetylcholine is the main excitatory neurotransmitter in GIT. This excitatory interneuron secretes acetylcholine, which stimulates further release of acetylcholine, which acts on M3 receptors and increases GI motility. This inhibitory interneuron secretes nitric oxide, and this nitric oxide inhibits the release of acetylcholine. So nitric oxide decreases the release of acetylcholine. Apart from that, there are dopaminergic neurons which secrete dopamine. And this dopamine acts on D2 receptors and inhibits acetylcholine. D2 receptors and inhibits acetylcholine. So let's recap once. There is a primary cholinergic neuron which secretes acetylcholine, which acts on M3 receptor on smooth muscles of GIT and increases GI motility. Then there are interneurons. There can be an excitatory interneuron which releases acetylcholine and causes further release of acetylcholine and increases GI motility. There can be an inhibitory interneuron which releases inhibitory neurotransmitter nitric oxide, which decreases the release of acetylcholine. There are dopaminergic neurons which act on D2 receptor and inhibit the release of acetylcholine. Apart from that, on excitatory neurotransmitter there are receptors. For example, 5-HT4 receptors. And on inhibitory interneuron there are 5-HT3 receptors. Mucosal stimulation leads to release of serotonin from enterochromaffin-like cells and also from myenteric neurons. These serotonin act on excitatory 5-HT4 receptors to stimulate GI motility. It can also act on inhibitory 5-HT3 receptors to decrease the GI motility via release of nitric oxide. So this is how 5-HT4 agonists are used to increase the GI motility. So this is the basis for use of multiple drugs. Now we will discuss the class. Also there are motilin receptors. Motilin is a polypeptide which is secreted from enterochromaffin-like cells of duodenum and jejunum. Motilin is a polypeptide which is secreted from enterochromaffin-like cells of duodenum and jejunum, and they act on motilin receptors. Motilin acts on motilin receptors on small intestine to stimulate GI motility. Now let's discuss the classification of drugs, and I will also tell you in diagram how these drugs act. So the first category of drug is cholinomimetics, the drugs which increase acetylcholine. The examples of drugs are bethanicol and neostigmine. So they increase the acetylcholine and thus increase GI motility. The second class of drugs is substituted benzamide. It is metoclopramide. The third class of drugs is D2 receptor antagonist. The name of the drug is domperidone. The fourth class of drug is 5-HT4 agonist. For example, cisapride, mozapride. So these 5-HT4 agonists stimulate these 5-HT4 receptors which are on excitatory interneurons and thus increase the release of acetylcholine. which increases GI motility. Now the fifth class of drugs is macrolides. In that the drug name is erythromycin. The sixth class of drug is CCK1 receptor antagonist. And the drug name is loxyglumide. The seventh class of drug is antipsychotic, and the drug name is amisulpride. Now let's start with cholinomimetics. So the first cholinomimetics is bethanicol, which is an muscarinic receptor agonist. It is used in GERD, gastroparesis, and urinary retention. The second cholinomimetic drug is neostigmine. It is an acetylcholinesterase inhibitor. Thus, it increases the concentration of acetylcholine and increases GI motility. It is used in intestinal pseudo-obstruction, which commonly happens in hospitalized patients and is also known as Ogilvie syndrome. Now the side effects are cholinergic side effects, such as bradycardia, diarrhea, increased secretions, increased salivation, nausea, vomiting, etc. So because of these adverse effects, these drugs are not commonly used. Now the second category of drug is substituted benzamide. That is metoclopramide. Now these metoclopramide drugs, what is their metoclopramide? What is its mechanism of action? It is a D2 blocker. So it acts on CTZ and acts as an antiemetic. in stomach. Because of D2 blockade, it increases acetylcholine and increases gastric emptying and motility. Because of that, it is used in gastroparesis. And GERD. It is also 5-HT4 agonist. So because of this 5-HT4 agonist action, it increases small intestine motility. By increasing acetylcholine. So it is used in paralytic ileus. And intestinal pseudo obstruction and constipation. It is also 5-HT3 antagonist, but that effect is seen only at high doses, not at normal doses. 5-HT3 antagonist at high dose. It is also used in impaired gastric emptying, which is seen in post-surgical syndromes. Post-surgical, which after which surgery is vagotomy, like we are cutting the vagus, or antrectomy, we are removing the antrum, and in diabetic gastroparesis. It is also used in non-ulcer dyspepsia, when metoclopramide and domperidone are not effective, and when other standard treatments like PPIs and H2 blockers are not effective. Now we will discuss domperidone. Before discussing domperidone, the side effects of metoclopramide are extrapyramidal side effect as it crosses the blood-brain barrier. The side effects we have also discussed in antiemetic section. I will just briefly tell you that they can cross the blood-brain barrier and block dopamine receptors in basal ganglia. Thus, they can cause extrapyramidal side effect, which include restlessness, dystonia, and drug-induced Parkinsonism. They can also cause hyperprolactinemia. They can increase prolactin levels. Normally, prolactin is under inhibitory control of dopamine. Now, since they block dopamine receptors on pituitary, they can increase the prolactin levels and cause amenorrhea, galactorrhea, and infertility. Now, domperidone. It is D2 blocker. It acts as an antiemetic by inhibiting D2 receptors in CTZ area. It also increases gastric emptying and increases gastric motility. So it is used in GERD and gastroparesis. It can also be used in non-ulcer dyspepsia. Non-ulcer dyspepsia means there is increased acid secretion without any ulcer. When proton pump inhibitors are not effective alone. They can also be used to promote lactation. Domperidone does not cross blood-brain barrier and is free from extrapyramidal side effect, does not have extrapyramidal side effect. However, it causes hyperprolactinemia in some cases, but the incidence is lesser than metoclopramide. Now the next class of drugs is 5-HT4 agonist.